let's get started. This is my fun topic. This is my fun topic, okay? I sort of like this better. Because you can do so much for these patients, spinal cord patients and neuromuscular disease patients. I'm writing an app now, even though I haven't got a cell phone or a television set. I'm working on making an app because I want to direct people from all over the world to centers that can maintain them non-invasively, so they don't go into respiratory failure and get intubated and trached and all of that. So there are really 6 aspects of what centers can do. There's pediatrics and adults. Now, being a physiatrist, I can take care of both. I take care of babies with SMA type 1 and old people with ALS. There's also long-term management, where you put the patient on ventilatory assistance when they get symptomatic and have difficulty breathing, and they eventually get weaker and become 24-hour vent dependent without ever going to the hospital or developing respiratory failure. Now, some people do that. Neurologists or rehab docs or pulmonologists can do that, but they may have no access to the patient when they get sick. So let's say then that you got a patient on 24-hour ventilatory support using a mouthpiece and whatever, and they get pneumonia. In Brussels, there's a big rehab institute where they manage everybody. They go there to live with neuromuscular disease, and they manage them non-invasively. But when they get sick and they get pneumonia, they go to some hospital, and the people in Brussels have no say at the hospital, so the patients then get trached, okay? However, that's not necessary. They can be extubated back to what they were using, non-invasive support. So that's the second thing. And then, of course, you can remove the trach tubes of anybody or most people who require ventilatory support, or even if they don't require ventilatory support. And I'll tell you the criterion for that. What we teach the patients is very simple. As long as their oxygen saturation is normal in room air, they don't have any problems. Stay away from doctors and hospitals. You don't need x-rays, you're fine. Not only that, if the saturation is normal in room air, the CO2 is not bad, the airways are clear, and you don't have any significant lung disease. If you get a cold and your cough is weak and your secretions are building up, and if you can't cough them out, the saturation goes down. So I always tell my patients, if the saturation is 94 or less, there's only 3 possibilities. Either your CO2 is high, and you can get quite symptomatic from that. You can get symptomatic from that. Or you have secretions in your airways that you're not clearing. And if that's the case, and you don't get them out and get your saturation back to normal, you're going to end up with lung collapse, gross atelectasis, pneumonia. It's really not rocket science. It's as simple as that. So when my patients get respiratory infections, they stay home. They use their ventilators very often around the clock when they're sick. Even if they don't need the vent 24 hours a day when they're well, they're going to need it 24 hours a day when they're sick. They use something called a CoughAssist to clear their secretions, which I'll talk a little more about. So this is actually a patient in our, a spinal cord injured patient, a 72-year-old, and she's having the CoughAssist used on her to clear airway secretions. Now, I showed you these 2 brothers before. I don't think I told you a lot about them. I showed you the picture of them when they were at Yankee Stadium in 2010, and this is more or less what they look like now. Okay, this is actually last year. They have, at best, very trace movement of their eyes, and frankly, I cannot see the movement. My vision's not so good. But the mother seems to know if they're saying yes or no by looking at their eyes. But I mean, they don't have any facial movement at all. Not the slightest grimace, not the slightest eyelid movement or finger or toe movement. They have absolutely nothing, and they have 0 vital capacity for over 10 years. Now, notice something interesting about them. They have NG tubes. Both of them have had NG tubes since they were 4 months old. Now, this is amazing, too, because when I extubate somebody to non-invasive support, I always remove their NG tube because the NG tube will interfere with nasal ventilation. Now notice these guys have been on nasal ventilation for 38 years between the 2 of them, okay? But they don't even notice the NG tube. They've had it since they were 4 months old. You know, my first wife was very ill, and she had a bunch of things done to her, and she said the worst thing was the NG tube. She said that was unbearable. That was really, really horrible. she said. And yet these guys, they don't even notice it. The brain gets used to anything, you know, gets used to anything. Anyway, so isn't that interesting, though, that the NG tube doesn't interfere with their nasal ventilation at all? You know, so a common sense would be to remove the NG tube to permit nasal ventilation, and that's what most doctors think you need to do, but, you know, it's not necessarily true. Now, this is a typical SMA type 1 child. I told his parents that he'd be dead if he didn't get trached. Now, he's 1 year old, so he's typical. He was not 24-hour event dependent when he was 4 months old. In fact, he only became 24-hour event dependent when he was about 13. So he's a relatively mild, typical SMA type 1. The interesting thing about him was he was intubated 10 times before he was 4.5 years old, and 3 times he failed extubations in New York City hospitals, got transferred to us, we extubated him in 24 hours and sent him back home. There's something else interesting about him. One of those times he was admitted to New York University Hospital, my alma mater, that's where I did my residency, and he was told by a physician, probably a resident, that he was dead. So, you know, he said to the parents, well, I'm so sorry your child is dead. And so the parents started crying. The father picked him up, put him on his shoulder, you know. And then after a period of time, he heard a grunt. He's not dead. He's not dead. Could you imagine telling the parents that your child is dead when he was not dead? You know? And you figure, this is New York University Hospital in the 1990s, right? They didn't know if somebody was dead or alive. Could you imagine 2,000 years ago? I mean, that's just one example, okay? But they couldn't tell whether he was dead or alive. No, I wasn't there. No, the parents told me this, see? But now, why was he intubated 10 times before the age of 4.5, whereas the other 2 boys, I never told you this, but they were hospitalized once each for respiratory failure and intubated once each. One of them was 8 years old, the other was 12 years old. So we had them intubated for over a week, and once their lungs cleared up, we extubated them, sent them back home. But that was it. I mean, this boy, the younger one, became 24-hour event dependent with no hospitalization at all when he was 4 months old, okay? The older boy was admitted to a hospital for diagnosis, not really for ventilator use, but that was a different matter. But the only time they were intubated was when they were 8 and 12 years old. Amazing, I think, you know. But him, 10 times. I'll tell you why. Because he has 4 older brothers and sisters. And they kept bringing disease germs home from school, and he was getting sick, and that was the problem. Now, after 4.5 until he was 16.5 years old, not a single hospitalization. But when he was 16.5, he had bronchitis. And he was exhausted. Days of 24-hour using the CoughAssist. And so we put him in the hospital. We intubated him for 24 hours. He slept. And after 24 hours, we extubated him back to nasal ventilation and sent him back home. He hasn't been hospitalized yet. And now he's 23 years old. He hasn't been hospitalized since. This is typical SMA type 1, 23 years old. We have over 70 patients like him. And about 20 of them now are approaching 20 years of age. This is a severe Duchenne. He started non-invasive ventilation for sleep at 12 years of age, was 24-hour event dependent by the age of 14. Using a mouthpiece like this during the day, and he used a lip seal at night, which I'll show you. Anyway, here he is at 41. That's 27 years of 24-hour non-invasive ventilation. 25 years. Now notice he's got a microphone holder from Radio Shack, okay? The microphone holder holds the mouthpiece by his mouth. So he grabs it when he needs a breath. And he needs about 4 breaths a minute. Now, why does he need 4 breaths a minute? Even though at this point his vital capacity was about 60 milliliters, minute ventilation, normal minute ventilation is about 6 liters. Now, you can get that by 12 breaths of 500 or 4 breaths of 1500. So we would set all the ventilators at over 1 liter, see? So he has a little bit of inspiratory capacity, and he takes a deep, deep breath, you know, from the ventilator, and so he doesn't have to grab it that often. Now, these patients, by the way, sometimes the first complaint is that they're losing weight. They don't have an appetite. Now, they may lose their appetite because their CO2 is high, but they also lose their appetite because they may be breathing 40 times a minute, so they only have 1 second to swallow. you know you cannot swallow and breathe at the same time. You will aspirate, right? So if you've only got 1 second to swallow and it's difficult to trigger your swallowing mechanism, it's very difficult to eat. So we often put the mouthpiece there for them to use for meals. If you give them 1.5 liters of air, now you got 15 seconds to swallow, you see? And then they gain weight and they do fine. Then as they get weaker, they start really needing the mouthpiece, you know, other times during the day. We have over 100 patients like this. And many of them we remove trach tubes to put on non-invasive ventilation. This woman, we were talking about dentistry a second ago, as being perhaps a wiser profession choice at this point. But this woman was very intelligent, very wise. She was very beautiful, and she was very courageous. She was 29 years old. She just graduated out of dental school. She was diagnosed with ALS. Her boyfriend knew the diagnosis, married her, and she was dependent on mouthpiece, non-invasive ventilation for a little over a year, but then her bulbar muscles deteriorated, and she refused to get a trach. She didn't want to be a burden on her husband. So, how young can you be and be diagnosed with ALS? Any idea? ALS, classic ALS. Well, our youngest patient now is 10 years old. We had an athletic 10-year-old who all of a sudden got so weak that within 1 year, he was 24-hour event dependent. He lost everything. Anterior horn cell disease, indistinguishable from ALS by 11 years of age. And he decided, he was so depressed, he just wanted to die. His parents let him die. But he used non-invasive ventilation for a while. This is an ALS patient whose trach tube we remove. So how do we remove the trach? We cap the trach, put them on non-invasive ventilation, let them practice it, and then we take the trach out. And this is an ALS patient who wrote serial killer books. His name was Philip Carlo. He wrote The Iceman. He wrote a bunch of other books. He was the first guy to write about pedophile priests. And he was in Holland, and he wrote about the fact that the Dutch parents some of them were renting their children out as sex slaves in Holland. I mean, it's unbelievable. He wrote a book about this. Then he got into pedophile priests, and then he started interviewing serial killers. He was quite a character. He would go to death rows and all these, places and interview these guys. And anyway, so he was also on non-invasive ventilation for about a year plus, and then he got bulbar and died. This woman has been doing this now for 61 years. I'll tell you why I specialize in neuromuscular disease, because when I started out in rehab, I saw general rehab patients. And I'll never forget some of these people. One of them was a ski racer, a woman. She must have been about 28 to 30 years old, a ski racer. She was so flexible that she could put her hands flat on the ground, maybe a foot or two in front of her. I've never been able to get much past my knees, okay? But that's how flexible she was. And she was very athletic. But she'd never worked a day in her life because she has severe fibromyalgia. So if I touch her back, the pain goes down my leg, up to my head, everywhere. She never worked a day in her life. This woman has been full-time employed for 31 years. She has no movement below her neck, and she's been respirator dependent for 61 years. So what is disability? Every year in the United States, we have another 4 million people on disability. 1/6 of the population is on disability, and another 1/6 is on food stamps. Pretty soon, the majority will be living off of the rest of the people who work, That's not the way it works in some countries like Singapore and China and so on. Anyway, this woman is remarkable. She is a rehab counselor, and she knows how people with disabilities can get everything in the state of New York. She works for an institution called Independence Care Systems. It's what they call, I won't get into it. Let me just tell you, she's a very valuable person. And she supports herself. She uses a lip seal for ventilation during sleep. That's what a lip seal is. See, until I wrote the first paper on nasal ventilation support in 1987, the only thing that was available was a lip seal. All of my first patients were using lip seals for nighttime ventilation, and the mouthpieces for daytime. So this is another one of my patients, but this is before I knew her. This is 1954. She's 9 years old with polio in an iron lung. I met her in 1977. Now, understand this. This is 1977, not 1877. I met her in 1977. And at that time, she was using a sip and puff control motorized chair with the mouthpiece next to it, okay? And she's living, in 1976, she and a bunch of other patients like this picketed the New York City Board of Estimate saying, we want to go home and we do not want nurses. We want to hire, train, and fire our own attendants, okay? That guy I told you whose wife was not the most faithful person in the world, right? Well, his second wife was an attendant that he hired. He gets money from Medicaid, and with that, he can hire, train, and fire his own support. And I guess he liked the one who was supporting him, so he married Maria, and you know, she had been a nurse in some Latin American country, and she was an attendant for him, and you know, they got married. So anyway, self-directed people do not need nursing care. Self-directed people need rehab and to understand what they need and what to do for themselves. And until the government gets that message, we're going to be further and further in debt. Because this is the only stupid country in the world that if you've got a trach and are ventilated through it, you automatically get 24 hours, 16 to 24 hours a day of nursing care at $800 to $1,200 per day. There is no other country in the world that does anything that stupid. In Europe, some of the countries provide attendant care up to 24 hours a day, but not nursing care. Attendant care is 5 times cheaper, okay? And that's what she looks like now. Okay, this was like 1 year ago. She's still alive. She has also been 24-hour vent dependent for 61 years on non-invasive ventilation. This is a spinal cord patient whose trach tube I removed from Kessler because I ran the vent unit there in the early to mid 90s. And now she's 40 years old. She was 17 at the time. She had less than 200 milliliters of vital capacity. We took her trach out, put her on non-invasive ventilation, and she's still fine. Everybody with obesity hypoventilation can be managed non-invasively because their bulbar muscles, like spinal cord patients, are perfectly normal. That means, now this guy, when we took his, we either extubated him or took his trach out, I forget. I think we extubated him. But you cannot extubate him to BiPAP. Even if you set BiPAP at 35 centimeters of water, do you think 35 centimeters of water is going to move this blubber? It's not going to happen. He ventilates himself at 60 centimeters of water pressure. And he can do that because his lips and his bulbar muscles are strong. But, you know, he doesn't need a trach tube for ventilation. Nobody with unless they're, you know, they have brain injury and they can't cooperate, you don't need a trach tube. This is a man with lung disease. It's never been clear what happened to him, but he was normal physically, but he just couldn't breathe. And anyway, so we managed him non-invasively. This is another guy. This guy was in an explosion, destroyed his lungs. He was intubated 19 times in 20 years. He signed an advance directive, let me die. I don't want to be intubated again. So I went there, put the lip seal on, ventilated him. He woke up because his CO2, he was like that. It was agonal breathing. But we blew the air into his lungs. His CO2 came down. He woke up. And then he went home for 11 months using non-invasive ventilation. Now, physically, he was intact. He had to use a walker, though, to drag his ventilator around because he couldn't breathe at all, except by non-invasive ventilation, you see. So the big problem is paradigm. Physicians give oxygen to anybody who has a respiratory symptom. Now, the oxygen is the worst thing you could do for a patient who doesn't have lung disease, for a patient whose primary problem is muscle. Because when you give them oxygen, their CO2s go through the roof and they arrest. That's what happens. And so the most common errors are misinterpretation of symptoms. Now, this is something to understand. If you're able to walk, like if you have COPD or myotonic dystrophy, or maybe even Becker, your vital capacity may be coming down, but you don't get short of breath unless you're exerting yourself. You get exercise intolerance or exertional dyspnea, okay? People in wheelchairs don't get exertional dyspnea unless they're, you know, operating themselves, which they usually can't do. What they complain about is anxiety and inability to sleep. So they come into the emergency room with a cold, maybe somebody with a spinal cord injury or neuromuscular disease, and they'll complain that they can't sleep. They've got this cold, right? They're coughing and choking, and they're anxious and they can't sleep. Now, I have actually seen ER people get a psychiatrist to come and give them sedatives to put them to sleep. And they put them to sleep permanently. And it cost some of these hospitals money because they got sued. You need to be aware that a patient in a wheelchair who's about to arrest from a mucus plug is likely to complain of anxiety. Now, why inability to sleep? Because our ventilatory drive and our cough is depressed when we sleep. And we don't recruit accessory breathing muscles so well when we're asleep. Okay, that's why. But they don't tell you that's the reason. You got to know that. Pulmonary function testing is a waste for patients with neuromuscular disease. It's designed for people with lung disease. You're looking at plethysmography and diffusion. And people with neuromuscular disease, they have normal diffusion. They have less lungs, but they have normal diffusion. And forced flows, forced vital capacity. You think they need forced vital capacities? The forced vital capacity is equal to the simple vital capacity for people with muscle weakness, always, always. The only benefit of setting them for pulmonary function studies is that you could charge them $1,500 and maybe get paid something for it, that's all. Failure to monitor sleep. I don't normally monitor sleep. When I know that the symptoms correspond to the loss of pulmonary function. But if the pulmonary function is not so bad and the symptoms are so subtle that I can't decide if the patient is symptomatic or not, I do a sleep CO2 and oxygen saturation. Now, the American Thoracic Society guidelines are that if the CO2 goes over 48 during sleep, that's a reason for nighttime ventilation. That's probably not bad. I don't know. It's probably not bad, actually. But sometimes, too, the saturations dip like this, you see? And now when I see that, I show the patient, look, you're really not doing too well during sleep. You should try non-invasive ventilation. And I tell them that if it doesn't make you feel better, don't worry about it. You're not going to die from not using it now. Just come back in 6 months, a year, or if it's ALS in 3 months or 2 months, and we'll check you again. Because nobody's going to die by not being put on sleep ventilation sooner. It's not going to happen. It's really for the symptoms. If they don't feel better using it, the danger of trying to force someone to use it when they don't need it is that when they do need it, they won't want to use it. You see, that's the danger. And all these, American Thoracic Society and all these, American College of Chest Physicians and the neurology groups, they're so inappropriate. It's incredible. Like, so for example, they say anybody with ALS, you should pay for them to have a ventilator if their vital capacity is less than 50%. Well, I have had patients with 90% of predicted vital capacity sitting, and they have 40% when they're supine, but when they send them for pulmonary function testing, nobody tests them supine. That's another reason why it's inappropriate. But even with 90% of predicted vital capacity, they needed ventilatory support 24 hours a day. Why? Because you got to lose 40% of your inspiratory muscle strength before you begin to lose your vital capacity. So, and some of these patients progress so rapidly that even while their vital capacity is 90%, they can't breathe at all. Now, I have had other patients with 300 milliliters of vital capacity who had normal CO2, was totally asymptomatic, and would not use a ventilator and didn't need it with ALS. So to give a guideline like 50% is grossly inappropriate. It's grossly inappropriate. So I monitor sleep when I have a question about if the symptoms are real or not, and I don't send them for polysomnograms. Polysomnograms are programmed to interpret every apnea and hypopnea as being central or obstructive in nature, which is like blaming the brain and the throat for what the diaphragm cannot do, okay? It's also totally inappropriate, but you can charge $6,000 to $7,000 for a polysomnogram. You stick the patient in a hospital, you have a technician watch him all night, you put electrodes on his head, bands across his chest, a thermistor in his nose, electrodes on. They do everything except CO2, which is the most important thing to monitor. See, everything is inappropriate for these patients, and everything is designed to make money, but to do nothing to help the patient, which is why all these patients who don't come to us go into respiratory failure and get invasive tubes. Now, am I exaggerating? Yeah. John Finder in Pittsburgh does a great job, and Josh Bendit in Seattle does a great job. And there's a Mary Schroth in Wisconsin who takes care of kids, like with SMA. She does a very good job. But there's only maybe 4 or 5 of us in the whole country. There's Elisa Wolf in Chicago. But I can't think of anybody else. Nobody else is interested in preventing respiratory failure for these patients. And they all get tubed, and then the taxpayers foot an almost $400,000 bill for them, per year. Per year. And nobody cares. Taxpayers, spend our money, Arterial blood gases are almost never needed for these patients because if you stick them for an arterial blood gas, they hyperventilate because of the pain anyway. And with end-tidal or with the transcutaneous CO2 monitoring and oxygen saturation, I don't even get arterial blood gases when they're acutely ill and in critical care. I just don't. I rarely do. Nobody needs a tracheotomy, like I said. And if you suction a patient through a trach tube, how often do you get the left lung? How often do you get the left main stem bronchus? Less than 10% of the time. That's why over 80% of pneumonias are in the left lung. Suctioning is not useful. It's not very useful, okay? Now, the CoughAssist is non-invasive suctioning. It creates 10 liters of flow that brings secretions up from left and right. And again, I'll have to show you that. Don't even think about oxygen therapy until you've tried to normalize the oxygen by normalizing the ventilation and helping the patient cough. If a patient comes in with neuromuscular disease and you send them home on oxygen, they'll be back in respiratory failure sooner than if you do nothing at all for them. None of these patients should ever get oxygen at home unless they want to die. Oxygen works the same as morphine. So if you've got an ALS patient that says, I absolutely refuse, I am not going to get trached under any circumstances, I'm not going to change my mind. There's no harm in giving them oxygen. They'll die a little sooner. Maybe they'll be a little more comfortable when they die. But of course, then you can give them morphine too. That'll take away the shortness of breath. Now, the indication, the hospice, that's what they do. The hospice gives you some attendant care, but they make the doctor sign an order for oxygen and morphine. Now, why do they do that? To make the patient more comfortable? No, to guarantee profit. Because if the patient survives more than 6 months, they lose money. But if they can bump the patient off a little bit earlier, they actually gain money, you see? So as long as they can give the patient oxygen and morphine, the patient will die sooner and they have a greater chance for profit. It doesn't help the patient any. Well, unless they want to die, So, American medicine, it's really fantastic. You know what the World Health Organization rates American medicine? What number in the world? Does anybody know? No, it's not that bad. What did you say, 50th%? No, 27. Next to Slovenia. Do you know that France is rated first? France is number 1, according to the World Health Organization. Italy is number 2. I know Singapore is number 6. Now, do you know what the Singapore government pays for the health care of its people? 1% of its GDP. Do you know what the American government pays for the health care of its people? No, total cost is 18% of GDP. Total cost in Singapore is 4% of GDP. But of that, the government pays 1% in Singapore, and here the government pays 10% of the 18% of GDP, okay? Who pays the other 8%? The employers, and we do, okay, the other 8%. But Singapore is rated 6th. They live 4 years longer than we do, and they get far better health care. I lecture in Singapore regularly. And believe me, they don't get killed by overtreatment and invasive procedures like we do here. They don't. Now, I was thinking about my own family and all the useless procedures that have happened for me and us. My first wife, for example, she underwent the chemotherapy with the bone marrow transfer and all. I mean, in theory, a guy in South Africa said that some patients may have gotten cured by doing this. So everybody in America demanded it. They did 48,000 women this way, and all they did was die sooner because of the bone marrow transplant. Nobody got cured, and nobody survived longer, including my wife. When I was a kid, I had my tonsils out. There was no indication for that. Everybody had their tonsils out when I was a kid, okay? I had LASIK done because I was very myopic. $5,000 I paid, okay? Now, when you get older, your myopia completely resolves. But mine is not resolving. Now I'm having the opposite. not only can I not read without 5 different pairs of glasses, I need reading glasses to see a distance, okay? Because I had LASIX. So now I've got to have LASIX again to reverse the first one, okay? This is an example. These are all examples of overtreatment. My father had, he was diagnosed with benign prostatic hypertrophy. And in those days, maybe 20 years ago, they were shaving prostates for men who just had mildly symptomatic or even asymptomatic BPH. That's how he became impotent and incontinent, you know? I mean, in American there's a book by Otis Brawley about overtreatment in cancer. And he gave many examples and stated very clearly that it's the industries here that push PSAs to get men to undergo these, because 28% of prostate biopsies are cancer. 3% of men die from prostate cancer. And no one has ever shown that by treating the cancer, you survive, or by not treating the cancer, you die. No one has ever shown that. But they do PSAs on everybody, and they terrorize people to actually have the surgery. And you know why? So that Johnson & Johnson's can make more money on diapers, and so that you can make more money on hormones and chemotherapy. I'm not exaggerating. Otis Brawley was the head of the American Oncological Society. He wrote a book on this, Otis Brawley. And he went through all of this, even breast cancer now. The women who get mammographies are 3% more likely to get breast cancer. And now they're saying that mammography does not increase survival for breast cancer. That's what the new data is saying now. My wife, by the way, did have mammography, and it didn't do her any good. Again, that's just an anecdote. But now the data is coming out that even that has become. And do you remember when getting total body CT scans was a fad? Do you know how much radiation there is in that? 10% of the total radiation that you get in a lifetime, you get in one CT scan for that. That increases the risk of cancer by, I don't know, a fraction of a percent. But thousands of people are going to die because they got that CT scan that was completely unnecessary. And in this book I'm reading now, I read good books, don't I? Good nighttime, you know. They're saying that over 90% of the lesions that they find with those CT scans are incidental. They call them incidentalomas or incidentalomas. But they resulted in so much morbidity and mortality just for trying to diagnose what these things were that they were finding on those scans. American medicine, you know, it's American medicine. It's just incredible, incredible what we put up with. And, you know, I wasn't thinking to myself my tonsillectomy was an example of overtreatment, or my father's prostate, or my LASIX, you know, but when you put the whole thing together, the amount of money and morbidity and mortality that we cause in America kills hundreds of thousands of people a year. And I'm not making these statistics up. These are acceptable, you know, these are statistics. Well, one of the ways we're killing people and harming them is putting trach tubes in them when they don't need them. My patients become 24-hour event dependent without ever going to the hospital. And they're my patients. Nobody else does this because you get more money for letting them get into respiratory failure and making the nurses happy, you know, by paying them $1,200 a year, $1,200 a day for the nursing agencies, you know. So anyway, by the way, back a long time ago, I published a paper saying that the full-time non-invasive ventilation users had the lowest pneumonia and hospitalization rates than patients with trach tubes. Something turns off the drive, but it makes the oximeter useless. So, you know, even in our own surgical ICU, we extubate patients and so on. And then I go back, I say, absolutely no oxygen. And I see he's on 25% FiO2, right? Saturation is 100%, he's on 20. What are you putting him on 25% for? He says, well, it wouldn't hurt him. Of course it hurts him, because if his sat goes to 94, you want to find out why. Either there's a leak in the system and he's not getting enough air, or he's got secretions that are building up, and if you don't remove him, he's going to fail extubation. It's not 25 is not going to hurt him. You know, it's you know, people, I don't know. So PFTs are great for COPD patients, and that's about it. Now, what's wrong with the trach tube? It's a foreign body. You cannot get rid of the pathogenic bacterial colonization. You cannot. There's as much pathogenic bacteria in the lungs of anybody with a trach tube as people with acute pneumonia. And that's been published many times. And that's what this was about. Also, trach ventilation users get hyperventilated. They keep asking for more air. Maybe because they're bypassing upper airway afferents. I don't know. But when I take the trachs out and put them on non-invasive ventilation, their CO2s come up to normal. That permits them to wean. Because if you're being hyperventilated and you're disconnected, you can't breathe. It'd be even difficult for us. But if your CO2 comes up to normal, you can wean. Trach tubes prevent weaning for these patients. And they decondition the diaphragms, you get atrophy, you get tracheal stenosis. 17 to 65% of patients have tracheal stenosis. And of course, you can die from hemorrhage, from fistula, tracheoesophageal fistula, from mucus plugging, all caused by the trach. In fact, 4 out of 5 ALS patients, my ALS patients who get trached and are on trach ventilation die because of the tracheostomy tubes. And that's what this article was about in 1993. This is now, do people live longer on non-invasive ventilation? Well, there's only data for Duchenne muscular dystrophy. In northern Japan, Dr. Ishikawa, until 1984, didn't do anything for the patients, and they all died at around the age of 18. Then from 84 to 93, 22 patients, all of them got trached. Now they're all dead at the average age of 29. Since 93, none of our patients have got trached, just like none of ours have ever gotten trached for failing extubation. And the average life expectancy is almost 40. So the Duchenne patients managed non-invasively live 10 years longer than trach patients. Now, is this also true for SMA type 1? I don't really know. I know you can live 20 or 30 years with a trach tube, and you can live over 20 years with non-invasive ventilation. But no one ever really knows if those managed by trach or non-invasive, if they die, if their average life expectancy is as good. I can't say. That's SMA type 1. Now, SMA type 2, 3, non-Duchenne myopathies and muscular dystrophies, I have no doubt that they live longer if they're managed non-invasively because they avoid the complications of the trach and they never die from respiratory problems. None of my patients die from respiratory problems. They die from usual complications of old age or heart failure. So they have to live longer. There are 3 respiratory muscles to understand. The inspiratory, which is the diaphragm, right, and the accessory muscles. The expiratory for coughing, and the bulbar innervated muscles. The most important of which is the glottis. Do you need, let's say you have no inspiratory or expiratory muscles. Do you need a trach tube? If you have no inspiratory or expiratory muscles, you have 0 vital capacity. You have no tidal volumes. So do you need a trach tube? Come on, I've been telling you this all day. No, of course not. You can use non-invasive ventilation. You can use CoughAssist when you get sick. You see, But now, we cannot take the place of the bulbar muscles. If you cannot protect your airway, you need a trach tube, And I'll tell you how to measure that. Now, do you need pulmonary function testing? Absolutely not. What you need is a capnograph, which is not part of pulmonary function testing. This measures end-tidal carbon dioxide. You need an oximeter, hopefully a more modern one than this one. They're $18 now, If you get them through a patient's insurance, the insurance will have to pay $300 for the oximeter, because that's what the home care companies charge. If the insurance company goes on to oximeters for less, you now can get them for $18, the same oximeter, okay? American medicine. This is a $15 peak flow meter, which I strongly recommend to you because it may be the last thing that we still make in New Jersey. This is made in Cedar Grove, New Jersey. New Jersey once had the biggest industrial base of any state in the country. All of that is gone, of course. It's gone to China and Southeast Asia. But we still make peak flow meters, I think. Now, if you go on the internet, if this thing says made in China, I'll have to take that back. But as far as I know, this is still made in Cedar Grove, New Jersey. It's $15. Every asthmatic has them. But we don't use them for peak flows. We use them for peak cough flows. And not just coughing through the thing. We use them for assisted cough flows. And I'll explain to you what an assisted cough flow is. And this is a spirometer. Now, this is not a digital spirometer, and you cannot use a digital spirometer. Because if you're air stacking, every time you stop a digital spirometer will so you cannot use this, as far as I understand. No, you cannot air stack and measure the maximum insufflation capacity with a digital spirometer. And frankly, I don't like digital spirometers. I don't like digital computers. I don't like digital anything. And you know, 2,500 years ago, the Greeks had a brilliant non-digital computer. It's called the Antikythera computer. Do you know about that? They discovered it in a boat that was sunk 2,500 years ago. It had 32 gears, and it did. It was a brilliant computer for all astronomical things. If any of you come out with a good digital computer, I'll be the first one. A non-digital computer, I will buy it. Okay, I think we need to go back to non-digital technology. That's my personal feeling. This is very sad news. Your vital capacities plateau at 19 years of age. You lose over 1% a year, like I said before. This is what happens with the severe SMA type 1s. They plateau at birth or a little after birth, like this kid plateaued at 4 years of age at 70 milliliters. That's one of the brothers I showed you. And then he went down to 0. With typical SMA type 1, they can get up to 200 milliliters before they start going down. With type 2, you can get up to 2 liters. With type 3, essentially normal or close to normal. Now with Duchenne, by the time they're 20 years old, their vital capacities are down to about 10% are predicted, and they need ventilatory assistance. Okay. This shows that as the vital capacity goes down, the cough flows become ineffective. Because, as the inspiratory muscles get weak, the expiratory muscles are getting weak too. And when the vital capacity goes below 40%, the cough is pretty ineffective. It's not very effective. So the goals are to optimize, to mobilize the lungs and chest wall so that they grow normally and that they stay compliant, to optimize cough flows, and to maintain normal ventilation. So how do you mobilize the chest wall and lungs? By air stacking. We use an ambu bag to air stack. So the patient takes a breath, he holds the breath, we give him another volume and another volume, and as much as the glottis can hold, that is air stacking, okay? Now, the difference between that maximum insufflation capacity and the vital capacity is a function of the integrity of the glottis. If your glottis is strong, you can hold a breath deeper than your vital capacity. So for example, when I frog breathe, my glottis is holding that air over my vital capacity, okay? If a patient with 0 vital capacity frog breathes, he couldn't do it if he couldn't close his glottis. It's the glottis that holds the air. So if your insufflation capacity minus your vital capacity is 0, in other words, if you cannot air stack, that means you cannot close your glottis. If you cannot close your glottis, your bulbar muscles have a problem. They're in bad shape, okay? And you can start aspirating saliva, your saturation can go down, and that's when you need a trach. If you cannot maintain normal saturation because of aspirating saliva, because your glottis cannot close, that's when you need a trach. The only time that happens is in ALS. It doesn't happen for any other neuromuscular disease. In SMA, they have no bulbar muscle function. They don't close their glottis, but because of positioning, they drool all day, see? So they don't aspirate, and their saturations don't go down, so they don't need a trach. Now, the big difference is that with ALS, they have stridor. And when you hear that, the CoughAssist will not bring secretions up. In SMA type 1, even when they're 20 years old, there is no stridor. And we get tremendous flow and able to get the secretions up. That's why they don't need a trach. That's why they don't need trachs. So you inflate them like this, and after you inflate them, you can measure the maximum insufflation capacity through the spirometer. And if the lips are too weak, you can inflate them through a lip seal or a nose piece or by frog breathing. Now, this woman has 900 milliliters of vital capacity. She could frog breathe up to 3 liters. So when she's sleeping at night, she could wake up and cough, and she can shout for somebody because she can frog breathe to 3 liters. Spinal cord patients do this, see? You cannot do this if you're being ventilated through a trach tube. You simply cannot. A patient with 0 vital capacity, frog breathes all day long. I had one patient argue cases in court in Virginia, frog breathing. He basically needed a vent around the clock, but he didn't use it during the day because he would frog breathe all day. And he was a lawyer, and he would argue cases in court that way. And now this is a 48-year-old with Duchenne again. And this is interesting, I think. See, this is his vital capacity from the age of 27 to 47. This is his frog breathing ability. And this is his maximum insufflation capacity by air stacking. So what you notice here is that even at 47 and 48, he was able to air stack to over 1.5 liters of air. His lungs were very healthy and very good compliance. Now, his ability to frog breathe, though, kept deteriorating as his glottis got weaker. And here it was saving him from using the vent all day. Here it was helping a little, but here it wasn't doing anything, see? Because instead of grabbing the mouthpiece 4 times a minute, he could grab it once or twice a minute when he was able to frog breathe. But then he got to where the frog breathing was no longer effective. His vital capacity went to 0. His frog breathing was not much better than that, and he had to use the vent all day. And I showed you this kid before. Now look at the difference between his lungs and their lungs. See, that's because of ventilation and because of the deep breaths that the mother gives them with the CoughAssist. See, I haven't really even talked about the CoughAssist. Okay, let's talk about the CoughAssist. Mucus plugging is what kills all these people. You get pneumonias and lung collapse. 90% of mortality occurs because of this. During colds, you need all 3 muscle groups to cough. You need the glottis to hold the air. Now, for a normal cough, you need your inspiratory muscles. You know, a normal cough volume is almost 2.5 liters. A normal breath is what, 500 milliliters, right? But people don't realize it. But a normal cough is 5 times that. So you don't empty your lungs to cough. You don't go, you go, okay? And that's the big difference. To do that, you need over 2 liters of vital capacity. So if a patient has a liter of vital capacity, they may have a normal CO2, but they may not be able to cough effectively. So you pump them up, you let them air stack. And as they air stack, then you can press on their bellies and you get the flow. That's an assisted cough flow, okay? You press on the belly somehow, and you measure that flow. Now, the assisted cough flow can be hundreds, 300 liters a minute. Unassisted cough flow can be 0. You know, spinal cord patients very typically. Now, this is what happens to the cough flows when you assist them by air stacking and pressing on their bellies, the abdominal thrust. And if I had to say, what is the #1 image to show why we never have to trach anybody, it's this one. Because if you can get effective cough flows so that they don't need to be trached, they can avoid intubations, and even if they get intubated, you can extubate them and cough their stuff out. They don't need to be trached. This is the CoughAssist in my office. Now, this was called a CoughLater. It's from 1952. Patients in the 50s were using these, and they would never give them up because they knew that that's what saved them from going into respiratory failure. So 2 of my patients put an article in the newspapers asking someone to make this thing. I went to every ventilator manufacturer, and nobody paid any attention to me except Jack Emerson. Emerson was the guy who put the iron lungs on the market in 1931. He made the CoughAssist for me in a 10-gallon paint can. He got it on the market in 1993. And the rest, as they say, is history. There are now 9 companies that are making these devices around the world. 9. They wouldn't exist if I hadn't convinced Jack Emerson to make it. And so this is a 72-year-old who, well, I showed you her before. These are different generations of CoughAssist. The nice thing about the Emerson, I mean, now it's been purchased by Philips Respironics, and it's called the T70. In Europe, it's the E70. At any rate, there are 2 nice things about the machine. It gives you pressures from 70 to -70 centimeters of water, and it allows you to measure the flows. So this is how I discovered that I was getting great flows from my SMA1 kids and no flows from my ALS patients. And that made me realize the difference was the spasticity and the upper motor neuron effect. The second nice thing about their machine is it has something called a cough track, where for babies, we time the machine to the baby's breathing, and it's not that effective. But the cough track will sense when they're breathing, and the kid triggers the machine to cough them. See? It gives them the deep breath when they inhale, and then they exhale, and it helps their exhalation. So that's very nice. And this is the new CoughAssist, they call it. You know, this fellow here fell out of an apple tree in his backyard. Walter. Ooh. But you need the room at 12?
Yeah.
Oh, don't worry. Don't worry.
Yeah,
Don't worry. I'll be finished by 12 easily. Yeah.
we need to leave here.
Oh, really? Okay. So I'll skip this. This is. Oh, you know what I want to show you though. Oh, ventilation. Yeah. Symptoms of ventilation are morning headaches, fatigue, hypersomnolence. You put the patients on nasal ventilation at night, not BiPAP. You don't need the EPAP or the PEEP. It's counterproductive. You put them on like a ventilator with a circuit that provides them with 800 to 1,500 milliliters of air through the nose piece. They use it at night. It rests their muscles. See, it's like a pickup truck. The ventilators rest their muscles. And these are ventilators that do that. Children you put on when they have paradoxical breathing, like I said. And adults you put on for symptoms of hypoventilation. And everybody's got a different kind of nose. So you have different kinds of nose pieces. Okay? That's the nose piece we use for infants. Like that. Okay? Now, they can leak out of the mouths, and sometimes they desaturate. And if they desaturate too much and they wake up, don't stuff their mouths. Don't cover their mouths with tape. Use a lip seal. Ventilate through the mouth. And you can ventilate through the mouth by using a lip seal. That's called an auricle. Or you can use this. Now, this is nasal prongs with a lip cover. It's called a Liberty or a hybrid interface. And it works very well. It's a closed system of respiratory support, like a trach with an inflated cuff. And that will normalize their ventilation. You don't need to use chimney bellows anymore, like they used to use in the 19th century. I told you this before. In 1953, this fellow described the mouthpiece ventilation, and I showed you them. Yeah, I showed you all this stuff. Okay. Yeah, that's funny. Must have had them in there twice. Now, the Respironics trilogy has something called a KISS trigger. The KISS trigger, see, when you set it back up right on a ventilator, if you don't take the breath, it throws air in your face. With a KISS trigger, it only gives you the air when you touch it. This way, there's no air coming at you all the time, see? And so they specifically have a mouthpiece ventilation mode in the trilogy ventilator called the KISS trigger. Oh, that's the second wife of this fellow here, Maria, putting on the pneumo belt. And that's what the pneumo belt looks like. Goes under the clothing, and it ventilates the lungs, okay? You measure them for it like that, and the ventilator inflates it. I told you that before. Now, extubation and decannulation. People need to be weanable before they extubate them. Otherwise, they think they need a trach. None of my patients are weanable, but we extubate them anyway. So none of you guys are going to be doing this anyway in critical care, so I can just refer you to some of my articles. So, I mean, this is a spinal cord patient, less than 200 milliliters of vital capacity. She was intubated on a Friday. I was away in Denver. I came back, and we extubated her to nasal ventilation, mouthpiece, and so on, you know. And the other thing is, we use the CoughAssist on patients with secretions. Our main extubation criterion is the normal saturation of room air. If they've got that and they're cooperative, we can extubate them even if they're unweanable. Patients get transferred to us from everywhere. We just published 250 of these patients with ALS, muscular dystrophies, polio, spinal cord injury, and so on. And we decannulate unweanable people too. And I don't have time to talk about that. This is an ALS patient who we decannulated. And we cover the ostomy and until the ostomy closes, and she goes back to using 24-hour non-invasive ventilation, as they do. Now, this is a spinal cord patient, an acute, his vital capacity went from 1,000 to 700, he got short of breath. So somebody put a chest shell on him, but the neurosurgeon needed access to the chest, so I put him on nasal ventilation, mouthpiece, lip seal. We removed the chest shell, and he had a decubitus ulcer. He used this for about a week and a half, and then he got, his vital capacity went up to 1,500. He went to Kessler for rehab, and he was fine. He never developed airway secretions. So the indications for tracheotomy is when you cannot maintain your saturation 95% or more because of chronic aspiration of saliva in the presence of upper motor neuron spasticity of the upper airway. Everybody prefers non-invasive ventilation for everything. These are people who are both on trach and non-invasive ventilation. And I guess I will stop there.